to turn that section out like this. Are you with me? Okay, so this is the view here. Now, it's only half of it for teaching purposes. There should be another half here, right? This is just one side. Can y'all see that? It's just this side. So the other side would be over there. Can everybody imagine that in this image? This is just half. So this image would be over there for the other side of the brain. This is just the left side. Okay? Everybody see the orientation here? Now, what this shows you is the outer part of the brain, the precentral gyrus here, has a map on it, and this map is called the motor homunculus. The word homunculus means little person. And the reason it's called motor homunculus is because, as you can see, the various regions of the body are distributed here in a logical and easily provable distribution. Now, neurosurgeons do this all the time in surgery. They have people in the room with them, and they have to remove part of the skull cap for whatever reason, removing a tumor, whatever they're doing. And they expose portions of the precentral gyrus. Now, the brain surface itself does not have any pain receptors on it, which means after you've anesthetized given a local anesthesia for the skull, and you've cut the bone off, you can wake the patient up with their brains exposed. You can ask them questions, and you can do things to them that are very interesting. One of the interesting things you can do is, because neurons are sensitive to touch, you can touch various portions of this precentral gyrus, and the muscles that these neurons control will contract in response to that. So if you know where the toes and the hips and the hands and the fingers and the face, where you know where these regions are, you just take your little probe and you just touch the cortex right there, and the patient goes sitting on the table. It is a phenomenon. I've seen it. Dr. Drup let me come in and watch this. It is a fantastically interesting phenomenon. There is a map of the human body on the surface of the brain at the precentral gyrus. Now, later in your lives, you will also learn this semester that the blue area here, just behind the precentral gyrus, the postcentral gyrus, also has a map, almost identical to the one on the precentral gyrus. This map is a sensory map. This is where your brain processes sensory information in a logical, organized, map-like fashion on the surface of the cortex. Now, these are cell bodies. In this red area, in an actual brain, it would look dark because the cell bodies are there and they're not myelinated. So it looks dark or gray in the appearance. Now, where does the information go next? All right, so if I'm on Miss Frizzle's bus and I begin on the cell body in the precentral gyrus, and I ride along that cell body until it becomes an axon, the axon is carrying the information. So that axon that starts somewhere here, I'm going out to the body now to make the muscle contract. That axon has to get to the muscle, most of the muscles in your body. It has to get there by way of the spinal cord. Now, I understand. Everybody looks at this picture, and the first thing that jumps out as students who look at this is there is an unequal distribution of information here. Right? There's a lot more dedicated space to your face and your hands than anything else. Does everybody see that? And so they look at that, and then I go to this picture, and they go, so you're telling me that the spinal cord controls the muscles of my face? No, that is not true. Okay, so you were thinking about face when I got here. I saw you look at it. You were thinking about it. And the truth is, the two nerves that control the muscles of the face are actually cranial nerves. They come off of the brain. So yes, we can take that information to cranial nerves to control the facial muscles. Yes. And those two nerves are number 5, the trigeminal, and number 7, the facial. This is just fundamental information for controlling the body, y'all. Cranial nerve 5 and 7 are the two primary cranial nerves controlling the muscles of the face. 5 controls the muscles of chewing. The temporalis, the lateral medial pterygoids, the masseter. We saw some of these in passing. I mentioned passing stuff. I'm not asking you here to go back through all that in your head, but I want you to hear it. The trigeminal is the chewing nerve. The facial nerve, cranial nerve 7, is the nerve of expression. So, the zygomaticus major and minor, the levator labii superioris, the orbicularis oculi, the mentalis, and the depressor labii inferioris. All these muscles that control smiling and frowning, and the corrugator superculi, and the concern, and doubt, and all these expressions, that is facial nerve. Cranial nerve 7 doing that. Okay, now that's out of the way. The rest of the body down, from the neck down to the toes, is controlled primarily by information out of the spinal cord. So the information starts in the precentral gyrus. And I'm on the bus, and I'm driving down the axon, and I want to go to some muscle. Okay? So how do I know how to get to the muscle? All right, so this picture is an overview. So as I come down the spinal cord, I have to pass through the brain. Now think about this, y'all. I'm not making additional connections yet. This is one cell. I got on board a single neuron in the precentral gyrus, and I can ride that axon all the way through the brain and through the brainstem into the spinal cord. I'm still on the same cell. And in some cases, like, for example, the control of your quadricep muscles, I would have to ride that axon all the way down to the spinal cord to the segment that's going to feed the quads. And those are L2, L3, and L4. So I'd have to ride it all the way down at least to L2. So where is, on the spinal cord, where is the second lumbar bone? It's almost to the bottom, right? It's where my spinal cord ends, actually. So if you put your hands on your hips, where your thumbs meet in the back is the second lumbar bone. So what I am saying, in some cases, a single nerve cell will travel from my brain all the way down my spinal cord. One cell, right? That long. No synapses to control the muscles of my legs. All right, so just to let you know the significance, there's really not all that much complication at that level, right? Just one cell. So now the cell is going to travel down the spinal cord until it gets to the spinal segment that is then going to carry the information out to the muscle. So the spinal segments are set up like this: C1, C2, C3, C4, C5. What am I saying? What's C mean? Cervical. And then I have T1. Okay, wait a minute. How many cervical would I have? 7, okay? Unfortunate. Unfortunate. I did not make this up. I think at some point anatomists, think they're so smart they got to do stuff like this just to keep everybody else confused. So if I come out between the atlas and the occipital bone, that nerve would be called C1. If I come out between the atlas and the axis, that nerve would be called C2. If I come out between the axis and C3, that would be C3. So the numbers are above the bodies of the bones, C1 through C7. On top of C7 is the cervical nerve, C7. Now, for some inexplicable reason in anatomy, I have no idea why they did this. The nerve that is on the inferior part of C7, I want to call it T1. Doesn't that make sense? But it's not. In anatomy, that one is called C8. From there down, from C8 down, all the numbers are numbered. The nerve numbers are nerves that are actually on the inferior aspect of the bone. So T1 comes out below the first thoracic body. T2 comes out below the second thoracic body. So the numbers change. Now, how many sacral bones do we have? One fused bone. But really, how many is it? It's like 5 bones that are fused in our body, right? Okay, so whenever you see a description of these spinal nerves, it will tell you that there are 31 pairs of spinal nerves. How many bones are there in the vertebral column? 7 cervical, 12 thoracic, that's 19. 5 lumbar, that's 24. A sacrum and a coccyx, that's 26. There are 26 bones and 31 pairs of nerves. How can that be? Because there are 5 sacral bones fused together. So the numbers are okay. Even though there's 26 bones, there's 31 pairs of nerves. All right, so as I work my way down, I'm going to pick the specific segment of the spinal cord that I need to go to the muscle that I want to go to. Now, it would be nice. It would be nice if these nerves came off of the spinal cord in a way that I could just go C1 to here, C2 to here, C3 to here, C4. And if you look at a picture of dermatomes, sensory stuff in the body, that's what it looks like. But that is not the way the muscles of the upper and lower extremity are controlled. This is where the details of anatomy get really, what's the right word? Frustrating, complicated, oh my word, difficult. This is where it happens, okay? So what we know is this. In the thoracic divisions of the spinal cord, T1 to T12, these spinal nerves that come off below T1, below T2, below T3, down to T12, those spinal nerves in the thoracic divisions do in fact go to the muscles in a segmental fashion that is predictable if you know your anatomical landmarks. So if I can find L2, if I can find C7, I can then think about segments as I work my way down. So you really, good news, you don't have to memorize which sections of the body are controlled by thoracic spinal nerves because they make sense. They come off and supply the muscles and the skin according to the segment of the spinal cord. Parallel, T1 across here, T2 across here, T3 across here. So you don't have to memorize any other additional details about those. If I have a muscle through here or a muscle through here, I can make an educated guess about which parts of the spinal cord are controlling them. It would be nice if the whole cord was that way. But all of these muscles and all of these muscles, you know, the muscles that move us, that give expression, you know, to our human existence, moving us around, all of those upper and lower extremity muscles are controlled by multiple spinal cord segments. multiple spinal cord segments. And this class is not going to require you to memorize those. Y'all, it's useful clinical information. The patient is presenting like this. The prototypical Herb Duchenne waiter's tip presentation. What has happened to this patient? What happened to them? See, if you've memorized the spinal cord segments and the muscles from all those segments, then you can explain that. The person had an injury that stretched the shoulder from the neck. Or the baby was born and they pulled the head too much lateral. Or the parent was swinging the child around by their arms and they stretched the lower plexus of the brachial plexus. You can begin to explain these clinical things if you know all the details. My job is to teach you the fundamental structure so that you can get there later in your life. So if you look up here at the top, it labels the cervical nerves as C1 to C8. But over here, you see a bracket indicating a cervical plexus. What that means is coming off of the cervical regions, in this case C1 to C4 or 5, coming off those upper cervical regions, the muscles that are controlled by those cervical segments of the spinal cord are going to get information from more than one spinal cord segment, which means an injury, a lesion, a tumor, some kind of whatever, abrasion, however you want to word it, something that happens to the cord. If you can look at that on an x-ray and you know which division that happened in, you can say something about what's going to happen to the muscles. You can say something about whether this person is going to have a sensory problem or a motor problem by looking at it on the spinal cord. The difficulty becomes that all of these upper and lower extremity muscles get multiple segments. So just injuring one part of the spinal cord will not cause a complete paralysis or a complete loss of sensation and anesthesia. It will cause more like a paresthesia, something a little loss of muscle tone, a little loss of sensation. So this is where the complications are. Now, you have heard this already in this class. You didn't realize it when I was saying it. But let me remind you, when we were looking at the atlas and the axis, I made a big deal about the dens articulating in the fovea dentis. Do y'all remember that? And I said that if you take your car seat thing out, you're going to risk having some whiplash injury and you could die because you could disarticulate the dens. You could pull that dens out of the fovea dentis and it would push into the anterior portions of the cord. Y'all remember that? Okay. When I said that, I followed up by saying that would mean that you would interrupt the signal from the brainstem to the third cervical division. And I know that all of the information that is traveling to your diaphragm to make you breathe comes from the third, fourth, and fifth cervical divisions of the cervical plexus. 3 divisions. So I mentioned it in passing. Earlier today, I said, you know, one neuron might be this long, and it would go to the quadricep. And I know the quadricep is going to get L2, L3, L4. 3 divisions of the spinal cord are going to feed this grouping of muscles in my leg. All right, so this is what I mean by a plexus. The cervical plexus and the brachial plexus are for neck and upper extremities. And what they do is they bring multiple spinal cord segment information to individual sections of muscles and skin. It's complicated. Now, this happens up high in the cervical area all the way down to T1. The cervical and brachial are high. Cervical is from C1 to C5. Brachial is from C5 to T1. These are the upper plexuses that complicate matters in anatomy. Down here, we have the lumbar and the sacral plexus. These are the plexuses that feed the lower extremity. So the complications are at the top and the bottom. And if you look at the spinal cord itself, it will tip you off that this is a place where there is a lot going on. If you look at the spinal cord here in the upper regions, and you compare it to the regions through the thorax, to the spinal cord in the lower region, you will see it looks thick on the ends, on the top and bottom, and thin in the middle. There is a cervical enlargement, and there's a lumbar enlargement. There's a lot of information here. The mass of the spinal cord is larger in the cervical and lumbar areas because there's so much more information to be traveling in these spinal plexuses, the lumbar and sacral plexus. Now, I haven't finished that. I'm going to go to the dermatome and the plexus to say this, say it 2 or 3 or 4 different ways. But I want to say one more thing before I start this. I'm driving on Miss Frizzle's bus, y'all, and I'm headed down the axon, and now you know I've got to go to the specific spinal cord segment that's going to go to the muscle. But now you know, in some cases, in a lot of cases, that could be more than one spinal cord segment. Okay, so I got to pick one. So let's say, for example, that I'm going to go to the bicep. So I know that the bicep is going to get information from C5 and C6. I know this because I know my brachial plexus. This is where it's coming from. So I'm on the bus and I'm traveling down the axon and I get to C5. I want to go to the bicep. Now, can I just make a right turn at C5 and go out to the bicep? And then you're right. It was rhetorical. You heard it in my tone, right? You can't do that. In fact, you have got to cross a bridge. And the bridge is actually a gap. So I'm going to need a runway. I'm going to have to come off the runway and cross over the gap to the next cell. So the second neuron, the other side of the bridge, the other side of the synapse, the second neuron is going to be located in the spinal cord, specifically in the ventral front portions of the spinal cord. Now, I haven't taught you spinal cord anatomy yet, okay? So this is coming. You get a little bit at a time. You put it all together as it comes. It's going to be on the front side. I'm going to have to cross the bridge into the motor neuron going to the muscle. Now, once I'm on that neuron, I can go all the way to the muscle. So how many neurons do I need to stimulate a muscle cell to contract? 2. That's good news, right? You would have thought, well, I need 100, but you don't. 2 neurons. One in the precentral gyrus and one in the spinal cord. So once you make that leap over to the second neuron, you can go out to the muscle. Now, all the stuff we're going to do is motor. I'm going to talk about Miss Frizzle on the motor bus, okay? This is a picture of sensory because I've said it a couple of times. The students always hear it and they go, wait a minute. Okay, so here's what I'm telling you. If you will learn the general pathway for the motor stuff, you will by default learn the sensory stuff. This is sensory. A dermatome is a piece of skin going with information back to the spinal cord. So you say, anatomy students, you tell me the number one place for back injuries is in the lumbar area. Be more specific.
L4 and L5.
Between L4 and L5 and between L5 and S1, right? This is where people normally hurt their back. Where does that pain normally come from? Do you see it? There's L5, there's S1, the dermatomes feeding the spinal cord. Where would that pain be? They say, I have Paul says, my sciatica's acting up, right? Where's the pain, Paul? It's down the right side of my buttocks here and down the lateral part, outside part of my leg right here. It's just so much pain coming from here. So this is the kind of thing dermatome images can tell you if you memorize them. But I don't like having students memorize this because you learn this as you go through the plexus stuff. So you see the thoracic thing segmented here? When I said bicep a second ago, what did I say? C5, C6. Did y'all hear that? Okay, so as you learn the motor information, you learn this by default. Okay, so here's the first one. I'm going to ask you to do some reading for me for class next time. I'm not going to beat you up with all of this, but here's what I want to do. I want to introduce you to the fundamental anatomy of the cervical, brachial, lumbar, and sacral plexus. So I'm just going to ask you for class next time, go on your online site or your text that you have. The Merriam text is so good. And do some reading for me on the cervical and brachial plexus. It will make your experience in here on Monday much better. One last thing. In order to walk you through that, I am going to sit in my office this afternoon and continue this class meeting. And I will post that online so that when you get to class on Monday, you will have an opportunity to ask me about cervical, brachial, lumbar, and sacral plexus. I am not then going to re-lecture that. You follow me? This weekend is a catch-up for me so that I can press on into the legs by Wednesday of next week.